You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites on iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now let's go beyond the abstract. Welcome back once again to another episode of Beyond the Abstract. We sure do appreciate you stopping by. We've got a great episode for you today. We're talking to Dr. Kory London and Dr. Phil Durney about their latest article featured in the current March-April issue of the Journal of Addiction Medicine, and it's titled Severe Fentanyl Withdrawal Associated with Medetomidine Adulteration, a Multicenter Study from Philadelphia, Pennsylvania. They discuss what medetomidine is, how it functions, and how its emergence in the fentanyl supply is impacting the opioid crisis in the U.S., as well as clinical management of medetomidine exposure and withdrawal in hospital and outpatient settings. All right, let's take a moment to learn a little bit about our guests. Dr. Kory London is an associate professor of emergency medicine at Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia, Pennsylvania. And he's also co-director of the Jefferson Addiction Multidisciplinary Service and director of ED Clinical Operations at Jefferson Methodist Hospital, where he also serves as stroke medical director. Dr. London leads the Department of Emergency Medicine's response to the opioid and overdose epidemic. His clinical and research work focuses on substance use disorder care in the emergency setting, including adapting care protocols to the eras of fentanyl and other opioid adulterants, the development of holistic healthcare ecosystems that support early recovery, as well as advocating for and evaluating the role of certified recovery specialists in the hospital. And how about Dr. Phil Durney? Well, Dr. Phil Durney is a physician and educator at Jefferson Health, where he also completed his medical training. Double board certified in internal medicine and addiction medicine, Dr. Durney serves as a clinical assistant professor of medicine at Sidney Kimmel Medical College. He holds key leadership positions, including inpatient lead of the Jefferson Addiction Multidisciplinary Service and assistant program director of the Addiction Medicine Fellowship. Dr. Durney is actively involved in expanding addiction consult services across the Jefferson system and contributes his expertise to Philadelphia's citywide council for inpatient care of patients with substance use disorders. He most recently has begun conducting research on the sustainability of addiction consult services to continue to provide much-needed services to marginalized patient populations. All right, now let's get into today's talk with Dr. Phil Durney and Dr. Kory London. And I want to start, and I'll let you both kind of answer and talk a little bit about the field of addiction medicine. Why addiction medicine? Of all the things that you could have gotten involved in, of all the medical fields that you could have pursued, what was it about addiction medicine that caught your interest, and what have your experiences been like in the field, up to this point in your career?
Yeah, so for me, I think it was more of an incremental interest in the field. When I was training at a Center City hospital in Philadelphia during residency, we were the primary teams taking care of most of the patients that were being admitted with substance use disorder. And over time, and after the pandemic, the volume increased exponentially. And when I transitioned out of residency to become a young attending, after seeing a lot of familiar faces in the hospital of patients that were being discharged and then immediately readmitted, I realized that there was a lot of opportunity working with this patient population and taking a lot of expertise that comes along with training in hospital medicine and applying that to a specific patient population, like patients that are suffering with substance use disorder. And over time, it led to a lot of really fascinating, rewarding projects to partner with faculty in other departments. We were all operating in a silo, and there was not really like a comprehensive, concerted effort to create a better care strategy approach to this patient population. So it required a lot of insight into quality improvement projects, care coordination, and really working to try to meet patients where they are and set them up for more comprehensive care when they left the hospital so that they weren't immediately readmitted.
Yeah, and so I am an emergency physician by training. We always consider ourselves to be one of the service specialties. Everybody who comes into an emergency department gets seen, and we do that regardless of their ability to pay or their chief complaint or anything. And that always was one of the most compelling parts of emergency medicine to me, is we are there when nobody else can be there for patients. When I came to Philadelphia, though, my specialties are really operations and quality. And what we saw is that there was a really acute need, as Phil was saying, to provide a more consistent and holistic approach to people who use drugs and when they need to be in the hospitals. So, really got jazzed about the idea of warm handoff and trying to approach people in the emergency department and help connecting them to long-term recovery services. And then, that's just being part and parcel of the Philadelphia community has expanded to the adulterated drug supply and really helping develop, as Phil was saying, an ecosystem of care that supports individuals throughout their acute healthcare needs.
We're going to jump into your study today, and we're going to be talking a little bit about medetomidine, and we have a couple questions around this. So let's start maybe with talking about what is medetomidine and how has its emergence in the fentanyl supply impacted the opioid crisis that we're seeing in the U.S. right now.
Medetomidine is what's called an alpha-2 agonist medication. It works on the adrenergic nervous system, so our adrenaline. It works to decrease the amount of adrenaline that works in our body by a feedback mechanism. And one of the problems with it is, as it is a veterinary sedative, it is not approved by the FDA for human use. And in reality, what it is it's a mixture of dexmedetomidine, which is a human-approved medication that we use in the hospitals, and it's an enantiomer, levo medetomidine. And as a comparison, and why we think that medetomidine has become such a challenge for us, is that it is substantially more potent, up to 200 times more potent than xylazine, which was the most common prior alpha-2 agonist adulterant to our drug supply. It is about 10 times more specific to the alpha-2 rather than the alpha-1 receptor. So there's some differences in how it impacts patients. And importantly, it also affects something called the imidazoline receptor, which is predominantly why it has caused such challenges in people's hemodynamics, their blood pressure and their heart rate, which is such a challenge to manage when patients start withdrawing from this substance.
So let's talk about your study. It found that about 77% of patients with medetomidine-associated withdrawal, they often require admission to the ICU for withdrawal management. So talk to me a little bit about what are the clinical challenges in managing this withdrawal compared to fentanyl and xylazine withdrawal, and how do you think that these challenges kind of impact addiction treatment and recovery for the patient population exposed to, this new kind of adulterant that you're talking about here?
I think the number one differentiating factor when you're specifically concerned about severe alpha-2 withdrawal and even more specifically medetomidine withdrawal is really the shift that we saw as a clinical presentation. So we saw an unprecedented clinical syndrome that really develops very rapidly as patients present to the emergency department. They are having really significant shifts in their hemodynamics. So they're seeing blood pressures, close to 200 systolic blood pressures. We're also seeing really increased heart rates up to 140s to 160s. And with that comes along really significant withdrawal symptoms. So really severe restlessness, anxiety, really significant intractable nausea, vomiting. That has significant clinical impacts because it really eliminates the possibility of administering several medications that we use to try to stabilize this withdrawal phenomenon. So we've been using a lot of clonidine, tizanidine, and most of those medications are available through an oral administration route. And when the patients are vomiting so significantly, it's not safe to give them oral medications. And in addition to that, to kind of compound that is also the phenomenon that we're seeing of patients becoming very encephalopathic or just confused and altered. They kind of develop this hypoactive cognitive state, which again makes giving oral medications more challenging from a nursing standpoint. With all of that coincides other objective findings that we've seen that we also discussed in the study of showing signs of, end organ damage like myocardial injury. In addition to the encephalopathy, we see patients that have also significant kidney injury as well because their hemodynamics have shifted so rapidly. And it creates, a really kind of critical care state to a lot of these patients in a rapid fashion.
Yeah. And the only other thing to add to that is that, the other problem with this is we are not in a community that is unfamiliar with alpha agonist adulteration. As I said before, xylazine was present for multiple years in our community. The challenge is not only the rapidity of these severe symptoms, as Phil was saying, but the also refractory nature to the previously effective treatments that we had been giving. So, again, even before patients are vomiting, we would give them very high doses of short-acting opioids. Our opioid withdrawal and adulterant withdrawal pathways used other medications like ketamine and gabapentin and other alpha-2 agonists like tizanidine and guanfacine, and combinations that were quite effective at helping mitigate the challenges of synthetic opioid, predominantly fentanyl and xylazine withdrawal. So we were using functionally the same treatments early on when medetomidine was first arising in our community, and they just stopped working. And that also was a very big challenge because so much of the work that we do is to try to destigmatize substance use and try to make it, normalize it as a normal part of the human experience, and the need to treat it as another medical complaint if it is problematic for when people are in the hospital. That was successful when we had successful means of treating that. Early on, when medetomidine came into our community, we were very ineffective at treating it, and it markedly worsened the hospital experience for patients, both because they were in agony, but also because all the healthcare workers who were trying very diligently, ordering huge doses of multiple medications at a time, were ineffective. And it really took us comprehensively coming together, the hospitals in our city, certainly our group at Jefferson, to rapidly iterate and change the way that we were approaching the treatment of these patients to try to help mitigate some of this agony and the sort of refractory nature of the initial care that we were providing.
Yeah, and you're touching on it a little bit already, but I'm wondering if you can kind of talk a little bit about how the findings from your study might be able to inform the clinical management of medetomidine exposure and withdrawal in hospital and outpatient settings. Like, what should some of these clinicians and folks interacting with individuals dealing with this, what should they know, and how should they be approaching this?
I think to best answer that question, you have to start with understanding what's happening in your community and your local drug supply. We were definitely surprised by how quickly medetomidine was infiltrating the drug supply in Philadelphia, and how quickly we were seeing, a shift in the clinical presentation of patients. It was a really, really, really severe, rapid change of a really decompensated, kind of unprecedented novel withdrawal syndrome. And in order to figure out how to best inform clinical management, I think step one is recognizing if it's possible that it's going to show up, to your emergency department, and figuring out, being on the lookout for that, being able to conduct an assessment clinically if this is something that is much more than just traditional opioid withdrawal. And then besides, we can talk a little bit more about like the medical stabilization that we're kind of implementing for alpha-2 withdrawal. But I also think besides the medical piece of this, there's a lot to be said of just aligning different departments in the hospital systems that you work with and trying to operationalize this. And Kory and I have spent a lot of time working with different departments and different members of the care team to develop best workflows for this, because again, the rapid nature of this doesn't leave a lot of time for not making an assessment, but also quickly administering medications to try to curb the severity of the withdrawal. So we've done that by, partnering with a lot of different staff in different departments, not just with other medical providers, but also nursing, pharmacy, care management in the hospital, and providing support for patients too. A lot of our patients come to the hospital out of desperation and out of really, really severe decompensation from a medical standpoint. So operationalizing things like order sets and making sure that medications are streamlined and delivered, and that care is streamlined, as well as like rapid assessments and trying to triage these patients, I think is just as crucial to determining what medical regimen they need to be on.
Yeah, that's absolutely right. And again, we can talk about specific medications. In general, it is just being very aggressive, and sort of just in an ideologic sense, is being very aggressive early on with patients. So recognizing that the rapidity of onset of what we consider to be medetomidine withdrawal is one of its hallmark features. So assessing patients routinely, being sensitive to even kind of subtle changes to their vital signs. If their heart rates go from the 60s to 70s, if they're potentially came after an overdose and they're being monitored to make sure that they do okay with that. If their heart rates start jumping up, that's the time to start treatment, even before they start talking about potentially feeling symptoms of withdrawal or showing signs objectively withdrawal. And this is stuff like oral clonidine, which is a very potent oral alpha-2 agonist. It's transdermal clonidine. And again, it's kind of the rest of the treatments that we use to try to manage both the synthetic opioid withdrawal and, again, manage this adulterated drug supply. So that it just give people medication early. Do not be worried that the person who has a heart rate that is normal at that point is not going to tolerate that medication, and be aware that if they do start to decompensate, that dosing has to only get more aggressive.
I wonder, looking ahead too, you talked about the emergence and what you guys have found in this study. Looking ahead, what kind of future research questions do you think kind of came from the case series, and how do you think that you might be able to address these questions? What kind of research studies would be able to help kind of address them and find solutions?
Yeah, so there's so much work that needs to be done about this, and you can frame this into buckets functionally. There's the social cost and the financial impacts to our healthcare system. One of the parts that we didn't talk about and sort of goes unsaid is many of our patients, previously they were coming to us from the community. They were, coming to us for, acute medical conditions, and we were treating their withdrawal as a function of, them being in the hospital for another condition. The xylazine was often wound management or infection based. With medetomidine, we're having people come from, ASAM level, 3.4, 3.5 and higher, places where that they should be able to receive treatment for opioid withdrawal or other types of substances, but because the profound nature of their symptoms are so present, they're coming to our hospitals. So we have work looking at assessing the impact of medetomidine in our community on utilization of stuff like the intensive care unit, how billing and sort of the amount of intensity of intensive. The intensity of critical care need is for this patient population, on top of separate buckets looking at how to treat certainly medetomidine withdrawal. And then I think the other big one is how to assess medetomidine withdrawal. There was a lot of controversy, certainly when xylazine became prominent, of whether or not xylazine withdrawal even exists, or whether this was a function of fentanyl withdrawal and other synthetic opioids themselves, or co-substance use with stimulants or cocaine. Medetomidine is pretty clearly showing signs that it does have a distinct withdrawal treatment and presentation. Using stuff like the COWS score that we use to manage and measure opioid withdrawal very well may not be appropriate, and finding ways to titrate medications and to monitor patients' need for treatment, both in the acute setting and then after the acute setting, is both very difficult and still certainly ripe for investigation.
You guys have been a wealth of information already today, and you had so much great insight into this topic. I do want to shift gears just a little bit and ask you for a bit more advice and wisdom. We traditionally kind of close the show out, and we ask for a little bit of wisdom for the younger generation of addiction medicine specialists that are up and coming. So I would love to know, based on your experiences and your journey so far, what kind of advice or wisdom would you offer to maybe your younger self just getting involved in the field, and as well as the next generation of addiction medicine specialists and providers who might just be getting interested in the field or might just be getting out there and working in the field?
I think for me, one of the most rewarding parts of working in addiction medicine is looking at the intersection that the field has with much more than just being grounded in medicine itself. So looking at the intersection with public health, advocacy, and working in the community. And I think creating a multidisciplinary or an interdisciplinary team is really such a crucial part of looking back on the journey of what we've gone through so far in Philadelphia, and how we've been able to continue to kind of meet the demand of what's happening with the drug supply. It's centered really in the fact that we have created such a well-rounded, dedicated, passionate team. And I think there's a lot of attention on medical stabilization, again, going back to looking for a standard of care approach for a lot of, unprecedented and novel withdrawal toxidromes. And the medical approach to that, or finding the correct evidence-based medical approach to that, is really just one piece of the puzzle. I think when you zoom out, you have to also think about how we can really meet patients where they are and work with them on a journey to recovery, if that's what their goals are. And besides medication, the bedrock of answering that question, I actually think, lies in navigation and support through the system. And that comes by having a really great team of addiction specialized social workers, certified recovery specialists, patient navigators, community health workers, and working with them to approach the patient in tandem.
Yeah, that's beautiful. I think the only thing that I would add is that I don't think that I recognized how wonderful and warm and welcoming the community of addiction medicine is. As an emergency physician who's dipped my toe into a number of different, we'll call them niches, I'm constantly blown away by how open people are, how willing they are to help people who are geographically distant, people who want to engage and work on projects together to really help what is one of the most vulnerable groups of people that exist in society. So my advice to young people is, if you are going into medicine and advocacy and impact are things that are important to you, unfortunately, addiction medicine is only becoming more important and more cornerstone to so much of the work that is done to mitigate the both medical needs of patients and the social related health needs of patients. And being at that intersection, it is a really foundational time to be able to not only craft science, but to help guide one of the gravest and most challenging types of diseases that humans have to experience. And so it's I'm incredibly grateful for all of the people that I've met in this field and all of the wonderful work that gets done. And I think that it's if you're looking for a space to join to really do some important work in this world, I think this is a great.
Dr. London, Dr. Durney, thank you guys so much for taking the time to talk with me today.
Thank you so much for having me.
Thanks for having us.
Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. And remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.